Hello, everybody, and welcome to the Downsized. My name is Christopher Durham.
I'm Laraine Durham.
And this is another in our series of chats with physicians, so medical professionals who, when we started doing these interviews, it was really our goal to bring just another level of conversation past it. So we've always done conversations with patients, and that, which has a lot of value, but it doesn't have the education, the research, the academia. So we wanted to raise the level of conversation. So this week's guest is Dr. Francavilla. Hello.
Hi, thank you so much for having me.
Absolutely.
Welcome.
So before we jump in, let me do the caveats. So first of all, I'm not a doctor. Lorraine's not a doctor. Dr. Francavilla is a doctor, but she is not your doctor. So make sure you talk to your doctor, your medical professional, and get a personalized treatment plan just for you. Although this is great information, it is educational information. It is not prescribing information. So talk to your doctor. Did I say that the way you would say it?
Perfect. Yeah, that's exactly what I say on my podcast. I'm a doctor. I'm not your doctor. Sometimes my patients laugh because they listen to my podcast. They're like, but you are my doctor. But it is still general advice, right? It may not all apply to you. You should always have an expert that you can consult one-on-one.
Well, and I talk because we report on like the research and stuff all the time, and people will always come back in the comments and go, but I'm like, yeah, it was research. You're the one person that's the exception. That doesn't change the research.
Totally. And that's why AI can't do my job quite yet, right?
Yep.
Because we have to be able to look at the individual.
Anyway, so the other thing we like to say is like and subscribe, and we'll tell you about Dr. Francavilla's channel. You can go like and subscribe to her channel as well. But right now, like and subscribe and hit that bell notification so you get an alert every time we publish something. All right. So just to give people a background on us, if you're new to us, Laraine and I have been on GLP-1 since September of 23. I have lost 103 pounds on tirzepatide, Zepbound, Mounjaro. I've moved around various things. And how about you?
I've lost 54 pounds on tirzepatide.
Yep.
Amazing.
So it's been a heck of a journey, and we've learned a lot along the way, and we want to help you guys learn. So let me welcome Dr. Francavilla again. Oh, so tell us a little bit about you personally first, and then we'll talk everything else.
Yeah, so I'm a family physician by training, but even in my training, I knew that I wanted to help people prevent medical problems through weight loss. And so that was an interest of mine, really even as a student. So by the time I finished my family medicine residency, I had done all the training to be an obesity specialist and hit the ground running doing both of those. So I've been out in practice for, I think, 11 years now on my own, treating obesity in the context of primary care. So the majority of my patients, I do their primary care as well as weight. And it's really because those two things go together. So I serve on the Obesity Medicine Association's Board of Trustees. I was just awarded their Clinician of the Year, which is probably—
Congratulations.
Thank you so much. It was like such an unexpected honor. So just honored to have that. I teach clinicians through a course I created called Help Your Patients Lose Weight. I have my own podcast, The Dr. Francavilla Show, which is for the general public, where I invite other colleagues on and also just have one-on-one episodes where I talk to the audience like they're my patients, the things that I would explain to them. And then I started a program last year called GLP Strong. And that is a strength training program for patients who are on medications like Zepbound or Wegovy so that they can improve their strength, improve their function, and preserve their muscle mass while they're on these medications. So I think those are the big things. My practice is in Colorado, and we have a team of 6 of us there doing family and obesity medicine.
So I understand it. If I lived in Colorado, I could schedule an appointment, and you are a regular primary care physician day in, day out.
I don't take very many new patients, unfortunately, right now, but I have a whole team that I've built out that are fabulous. And yes, we are taking people anywhere in the state of Colorado.
Oh, fun.
Good to know.
People always ask, they're like, how can I find a doctor like that? And we'll talk about that.
So if you're in Colorado and you haven't found a great team, check out, Green Mountain Partners for Health, which is our practice in Colorado.
Well, so talk to me a little bit more about the emphasis on obesity medicine. Did you, I don't think you've ever been overweight, but did you have a family history or where did that
Yeah, it's
interest
interesting.
come
As
from?
I have colleagues come on, so many of my colleagues who are interested in this field had a personal experience with obesity, and that was their interest. I did not. I do not have obesity, but I consider myself a really empathetic person, and I like the world to be fair. And it was really clear to me when I got into the medical field as a student that I wasn't special, meaning even though I do eat healthy and I do exercise and I do the right things, a lot of my patients, especially here in Colorado, were doing the right things. Or when they would start doing the quote right things, they weren't seeing changes in their weight. And so I really became interested in the science behind why some people struggle with their weight and why some people don't. I had a lot of interest in preventing diabetes and preventing cardiovascular disease. That is something that runs in my family along with obesity. And so wanted to, not see my patients go through the same struggles I saw in some of my family, which I think is something most of us have, right? Because they are such common conditions. So really came a place of wanting to treat the root issue for my patients. I didn't ever, if I never saw like a sick patient, I would be totally happy as a doctor. I like to prevent things. So I want to prevent people from showing up with a heart attack. I want to prevent people from having high blood sugars that damage their kidneys, damage their limbs, have these long-term consequences. And so to me, it seemed really obvious when I was in my training to treat this root issue, as opposed to waiting for people to have complications from weight and metabolic disease.
Well, and so I know you've talked about it a good way, and we've talked about it as well. You know, kind of goes into what you were just saying. Weight loss isn't really about willpower, right? It's about biology. Can you explain that and your thoughts there?
Absolutely. That's my favorite thing. If I could shout one thing from the rooftops, and I try to include in every conversation, both for my patients to really understand that it is not their fault, and also for people who make policy or have influence in the world or just don't struggle with obesity themselves and don't understand why other people do. So there are so many reasons why people gain weight. And I think that that's the first thing we have to recognize. There's genetic factors. There's certainly lots of environmental factors, including the fact that we as a society do move less. And we do have, a lot more foods that are nutrient dense and easy to access. There's things with the microbiome. There's socioeconomic factors. There's stress. There's medications that we often put our patients on that have side effects. There's a whole host of reasons why we have a problem with obesity in the world. But the reason why it's hard for people to lose weight is pretty universal, which is that our body kind of wants to stay at the same weight or slightly gain weight. And so when we start to try to lose weight, when we cut calories, when we work on nutrition, when we do the things that we're told to do, our body resists that. And it will do two things. It will slow our metabolic rate down. So we're actually burning less calories than would be expected based on our size. And a lot of the most interesting data from this came from the Biggest Loser studies, but there's lots of data on this, right? The Biggest Loser ones was just something I think everyone could relate to, and it made sense because they saw it happening in the real world. That is a harder problem to solve medically. And then the second thing that happens pretty universally to most people is that hunger changes. So you become hungrier when you are trying to cut calories and work on lifestyle, and you become less full and satisfied. So your hunger hormones actually change when you're trying to lose weight or when you have lost weight. And that's why people will say, oh, I lost my willpower. I just couldn't stick with it. I fell off the wagon. I just don't have discipline. And that's not it at all. It is biology, right? I've tried to come up with a good analogy to compare it to, but I think of it like having to go pee. There's some people who have to go pee more in the day. It's like very bothersome to them. They're like, I gotta go. And there's some people who can hold it longer, but eventually we all have to pee, right? And
So
that's how appetite is.
Are you saying that chronic dieting makes you hungrier?
Absolutely. Yes. And it depends on the type of diet, because if you are doing a ketogenic diet consistently long-term, which is very challenging for most people to do indefinitely, that will often suppress the appetite because of the ketones. So that is a nutrition strategy that I used to use a lot more before I had other more powerful tools because it would suppress appetite, but it's very hard to stick with it. But if you are just doing more of a traditional calorie counting and you're not in a ketosis all the time, then you are going to be hungry and you're not going to be full and satisfied. And there's lots of different sensations our body has around hunger and fullness that I like to dive into with my patients and figure out really what their root issue is. But ultimately, just know that it is a hormonal issue that is occurring when you have lost weight, that you are going to be hungrier. You're not going to be full and satisfied from food. And so, yes, to your point, chronic dieting can make this much worse because your metabolic rate, can go down every time you lose weight. It often does not restore your muscle mass. When you lose weight, you lose often some muscle, but when you gain weight, you usually do not gain more muscle back. And then you have these hormones that are changing, that are making you hungrier. So, it's very common. My average patient is a yo-yo dieter because they've tried so hard to do all the right things, but their body can only do so much. Their body is fighting it really hard.
That's so interesting. I've never heard it explained quite that way before. So I'm 56. I went on my first diet at age 10. So my whole life has been a yo-yo diet cycle. I've always felt extremely hungry, extremely driven to go get food. When's my next meal? That whole thing. And just to think about that, the dieting could have ramped that up. It's maddening, right?
But your story is what I see every day. That is such the story I hear. Well, when I was 10 or 12, the doctor said I needed to lose weight and my mom was worried. And so we did, Weight Watchers, or we, did this, a diet my mom put me on. And it just, it started this long-term relationship with food, as well as may have worsened some of the metabolic dysfunction.
Yeah. I mean, we talk to people on our YouTube channel who say that too. And, I always thought that, this was just me, right? This was just my problem, that nobody else had this problem. It was just my problem. And now I find out so many people grew up just the way I did with the chronic dieting and from the young age. So it's somewhat comforting to know that there's other people like this, and that, just getting back to the fact that obesity is a disease and it's not our fault, right? So
there's so much like shame around it. And we tell people over and over that it's something they can control. And so people do internalize it, and they do feel like they're the only ones struggling and they're the only ones who can't get it together. And, it's absolutely not true. So I'm glad it sounds like you're at a different place where you've seen that is not, you weren't doing anything wrong. You were just trying to fight biology. And so many people have a very similar story.
What's funny is we've talked to a number of people who have become angry when they realized the science of it, the obesity is a disease piece of it, because they've been bullied, they've been picked on their whole life. And these people who took this moral high ground also couldn't really take responsibility for that, because the opposite is true, right? Their biology is working in their favor.
Totally. So I have been writing a podcast for my show, in my head, it's not fully formed, but sort of the skinny people need to get off their high horse, right? So on one side, I think we're hearing a lot of these narratives of it's not your fault, obesity is a disease, it's biology, but we also need to fight this other side of just because you're lean doesn't mean you have been doing anything right. We've all been to dinner with you, we're all friends with you. We know that you may not be doing anything special, and you also may not be healthy, right? Just because your BMI is in the right place on the chart. So I think that's the next phase of activism we need to see here. Is the skinny people like myself, we have to get off the high horse and be humble.
Well, we all have that skinny friend who can eat junk food or fast food or anything and never seem to gain an ounce, right? And then, I look at myself, who I look at a donut previously prior to GLP-1s and gain 5 pounds. So and that was the dichotomy between me and my sister. So I was the chunky one and she was the skinny one. And it was always well, how come she can eat this and I can't? And So yeah.
That's a lot. I'm sorry. Like, I know how emotional that experience
Yeah.
is.
Yeah, for sure.
Well, so as a doctor and educator, you're out there, you've got a whole program that helping educate physicians. So what do you talk to us about what you're teaching them and
Yeah.
how you're helping healthcare providers
So my full
understand?
course is 14 hours
Yeah,
long.
like give us the elevator speech, obviously.
But I think, ultimately, I focus on what we call comprehensive obesity care, which means that we are doing, in my opinion, 5 things. We're looking for underlying causes. We talked about that root cause that everyone has, right? The metabolic decrease and the hunger increase, right? So that's universal, but there are so many individual struggles that may be related to menopause, PCOS, diabetes, hypothyroidism, rarely cortisol. We're hearing about that a lot right now, but that's rare, but something that should be worked up. There's binge eating often. I see a lot of people who struggle with alcohol abuse, depression, ADHD. So I teach my clinicians to look for those root causes that are making the situation worse or that may have caused the situation. And that also takes this burden off the patients to know that, or a medication side effect, right? To know that this wasn't their fault. So I think that's step 1. What are the underlying causes? And then the approach is pretty standard, I think, from what I'm sure heard from other doctors you've had on, which is, coming up with a customized nutrition plan that makes sense for that patient, increasing exercise. Exercise is so good for everyone's health. We should all do it no matter what. We're all going to live longer and live better. And so it's really not a thing about obesity. It's just complementing obesity care. Behavior change, which can mean a bunch of different things, but some of the different emotional things related to food, behaviors related to food, setting up your life to be more conducive to lose weight, and then finally medications or surgery, other medical interventions. So we're using all of those. And then one thing that often doesn't get taught is how to support people with maintenance, right? So we don't just treat this and then either refill your med forever or just stop the medicine. Of course, I'm sure you've talked about this on your podcast. If you stop the medicine, most people will gain weight, though you might be able to transition to another medicine or transition to something else. But if you need something to lose weight, you probably still need it, right? Whether it was exercising 4 hours a day, which is not a very great strategy long-term, or a medication. So really looking at all of that. And then I do have a bit of a passion for making sure we don't miss diagnosing eating disorders like binge eating disorder, because it's hard to progress long-term if we haven't identified and addressed some of those things. So, in a nutshell, those are some of the things that I emphasize in my teaching.
Is there an element of it that's really, I don't know how to phrase this. Let me tell you a story and we'll come out of it. We hear a lot about people seeing physicians who blame their obesity for other problems that are obviously unconnected. You're a broken arm, an ear infection, whatever, or who are just rude or really not nice people.
Yeah.
Is there an element where you're helping doctors communicate better? And
definitely, I show mock encounters with patients. So, and talk about some of the appropriate language to use. I suspect the people who are the worst offenders of that are not the people taking my course, but I do really try to emphasize that. And I do have some lectures I give that have some patient stories. One patient that always stands out came in and she kept having knee pain and she was going to different doctors and urgent cares and ERs, and everyone just kept telling her to lose weight. And I got her history and I was like, it sounds like you have a torn meniscus. Like that has nothing to do with your weight, right? Like skiers and runners and it has nothing to do with weight, and it's not going to get better whether or not you lose weight, right? And so finally was able to, get her an MRI, prove the diagnosis, and get her more appropriate treatment. But that is unfortunately something that patients with obesity face, is that they will see a clinician who blames everything on their weight. And while weight loss can help many medical conditions, our patients still deserve to have the right workup. And they probably need yes, having less weight may help your knee. And also if you need a steroid injection or you need a knee replacement or you need physical therapy, you still need those things. So, but it is a challenge, and, one of the things I'm known for in my field is advocacy work. And I like to encourage my colleagues, but also my patients, that small acts of defiance on those things and calling people out is advocacy work, right? Like, and empowering patients, or sometimes when I'll put referrals into specialists, I'll say, do not talk to this patient about their weight. Like, they know they have obesity. They see me, we have it handled. Like, they don't need to hear it from their orthopedic surgeon, right? Like, you don't know how to talk about it, so don't. Like,
well, but I think that's the other
great.
side of it, is a lot of doctors just don't address it at all for fear of whatever.
Yeah.
And when clearly it has impact on things, so there are medical reasons you talk about it. I don't know. It's just that whole, how do we compassionately have an honest conversation where we all get better at what we're doing?
Yeah. As a primary care physician, the way I like to bring it up is, let's say high blood pressure, which can be related to weight, and weight loss can improve blood pressure. I'll offer people all the other recommended things we should do, perhaps adding or adjusting a medication, watching salt in the diet, exercising, getting good sleep, reducing stress, reducing alcohol, all these things. And I'll say, one other thing that might help your blood pressure is weight loss. What do you think about your weight? And that's the opportunity for someone to tell me, oh, well, I've already lost 50 pounds, or, oh, I'd like to lose weight, but nothing has worked. Do you have anything that would help me? And then some people, of course, will lose weight or are already a healthy weight and they still have high blood pressure. So I like to use that language of like, one thing that might, I don't know. I don't know if any medicine is ever going to solve someone's condition. And I don't know if weight loss is ever going to solve a problem someone's having. So just being open to like, let's see. And if it's a strategy you want to try.
Well, so it leads to what's the most important thing you talk to people that are thinking about GLP-1s? I saw a commercial for these things. My friend lost weight, whatever, and they're curious in front of you. What do you?
I think the most important thing is to know, for most people, we think right now these are going to be a long-term medication. I do have people who have transitioned off and on to other oral medications that are older. But if you need a medicine to lose weight, there's a good chance you'll need to keep taking some sort of medication. It might not be the GLP, it might be something different. And certainly in the future, we're going to have more and more medications. So, people will step up to stronger medicines. Maybe they'll step down to weaker medicines. Maybe we'll have more and more tools to help tailor what is the best medicine. But if you need a medicine to support your weight, you probably will keep needing that. And so really making sure people understand that we can certainly try and see how they do off the medicine, but the expectation going in is that you are going to need to take it quite long term. I think that's the biggest thing to know going into those medications, and that the meds are a tool. You will have better health results if you also eat a healthy, balanced diet, like all of us should, regardless of our weight. And you will have better health results if you also move more, which all of us should, regardless of our weight.
I've heard other people say their doctor wants them to come off the medication for maintenance or at the end. How are doctors being educated, if not by you, on the latest science? I believe, like you said, these are tools. I needed it to lose. I'm going to need something to maintain long term. But how do physicians get that message?
Yeah, unfortunately, if they've already graduated from school, we're on our own to pursue continuing medical education and learn these things, right? Yeah. So, they may get it listening to my podcast. They may get it from a pharma rep in their door. They may have to learn from experience, unfortunately, that their patients really do gain this back. And so right now, there's data that although many physicians are prescribing these medications, most of them actually don't feel like they're highly educated on them. So, everything any of us in the community can do that are passionate about this, hopefully different prescribers and patients are going to come across, your tools, my tools, all the things that are out there, and really get a better understanding of what this experience might be like. And hopefully we'll also have more data of what this looks like long-term that we can actually base this on, because we don't have like 10-year data, on weight loss and what happens and what other strategies may work, who does need to stay on the med, who doesn't. But what I recommend to clinicians and to patients, because you may have to push for this, is that you have a regular check-in if you are tapering off the medication, and that if you are regaining weight or you're really struggling with thoughts around food or hunger, that you feel comfortable restarting or increasing the dose of the medication, and that it is not a failure. It really is just the biology. And so most of my patients who have transitioned off for whatever reason it may be have been sort of quite desperate to restart the medication because it has been so challenging for them to maintain weight. And it makes sense. I mean, they're like you, they've struggled since they were like 10 or 12 years old, and taking a medicine for a year or two is not going to change most people's biology that much.
Right.
I mean, we get comments all the time. My doctor won't write it for me now that I'm at a healthy BMI. My insurance won't pay for it now that I'm below this BMI. My doctor told me, and I know this one was just wrong. My doctor told me that Lilly won't sell it to me because I'm at a healthy BMI, even through Lilly Direct. And I was like, correct me if I'm wrong here. It's like, they're basically a pharmacy. If your doctor writes the prescription, they'll fill it.
Yes. And so, yes. So what we generally consider amongst, my expert colleagues that do this full time and have taken the board exam and write the papers on these sorts of things, is that we're really treating that highest BMI that someone has had, because we know that most patients' tendency is going to be to go back to that highest weight they've been at. And so just like blood pressure, if you came in, to the office with a blood pressure of 170 over 110, I don't care how many times you have normal blood pressure over the next 10 years, you still have hypertension, right? If you were on a medicine, I'm not going to take you off the medicine to prove you still have hypertension. Now, if you start going too low, which can occasionally happen, then I'm going to back off on that medicine, right? But if you just keep coming in and you have a normal blood pressure, I'm not going to stop that medicine to prove that you have hypertension again, right? That would be silly.
Yeah.
And so we mostly think of obesity the same way. Of course, people have to stop the med for all sorts of reasons, sometimes financial, sometimes supply, sometimes they're trying to have a baby, all these reasons that might need to stop the medicine, but we should still be supporting our patients and not hesitate to, add a new intervention or restart it if they're regaining weight, because it's biology. It's not their fault if they're regaining weight.
Yeah, exactly.
Also, maintenance strategies. I mean, Laraine and I are kind of the polar end. So I'm on 15 and have been on 15 now for 5 months.
Tirzepatide.
Of Zepbound, Mounjaro, tirzepatide kind of thing. And I don't have any desire to go down whatsoever. I've added some calories in, and I've been maintaining now, I don't know, 7-8 weeks. I'm feeling fine. And she's dropped down to 5.
Yeah. So I went as high as 12.5. And then I thought I was supposed to come back down. This was about a year ago. So I started coming back down, and I was on 7.5 for about 20 weeks. And I just kept dropping a pound every couple weeks, not a lot. But then, so I dropped to 5, and I said, well, let me see how that works. And so I've been on 5 about 4 weeks. My hunger's fine. I don't seem to see any difference. So I don't know. I think, and plus just thinking of going forward in the future, our insurance doesn't cover anything. So if at some point, maybe I could go on a Lilly Direct dose, and the lower the dose, the cheaper it is. So that's kind of what I was trying to get to, just to see if I could do it.
Yeah. Right now,
that's more
actually,
than
they're 5, 7.5, and 10 are all the same dose price. But certainly people use strategies to mitigate that and have creative strategies to do that. But that is the question. I would say that is the question I've gotten for the last few months when I go to colleagues' offices or family physicians who maybe don't spend all day thinking about these things. And we don't know. Like that's where I say, like, it's really going to be patient specific. My standard answer thus far is that, whatever you do to lose weight, you have to keep doing. So I would expect more often than not, we will continue people at the dose they ended up on. But I find some people, really want to get to that 15, but maybe they're tolerating a little more side effects than they would like to have long-term, like a little more nausea or symptoms on it. And so at maintenance, they may want to try to back down and see if it's enough. And then I've had a few people where like their weight loss has just been so dramatic that, we were like, well, I think like we really need to slow this down. And so we back down also. And I think that's why we really need to, these are not meds that you just prescribe once and like set it and forget it. Our patients deserve to have some sort of interaction, whether that is virtually, whether that's messaging, but it's going to have to be customized, and this is all going to get more complicated. So, we have new meds that are going to be emerging. We're going to have more powerful meds. We're going to have meds that work, on 3 different hormone receptors. And so there's going to be more and more nuance to this. So it'll be interesting to see if that means that people who've dabbled in this, like, get less interested and refer more to experts, or, what that solution ends up being, because we're just at the beginning of all this. And we're really going to have to meet our patients where they're at and figure out what works for them, as opposed to just, assuming the one with the highest weight loss results is the right med for everyone.
Well, I think it's interesting because, if you watch Wall Street thinks, well, whatever the highest weight loss is who I should reward with stock price, right? So retatrutide numbers come out and they're like, oh, stock price goes up. I don't know that that number, I've lost 36% of my body weight. That so exceeds any tirzepatide study. So to me, when I look at it and go, well, theoretically, at some point in the next 2 years, Lilly has orforglipron, tirzepatide, and retatrutide. It becomes exciting to me, not because of one of those drugs, but because instead of just the 2 big hammers we have in tirzepatide and semaglutide, you as a doctor can more precisely help me.
Yeah. Yeah. It's going to be very exciting. And, but we really need people who have a little more nuance, I think, or interest in knowing what makes sense. And to your point, like, the hot topic right now has become, not all weight loss is the same, right? And so we want to make sure people are losing fat. That's what we want. We want adipose tissue.
Right.
We want it ideally to be like central adipose tissue that's having those metabolic health. We want you to lose fat in your liver, right? Like we want you to lose fat and maybe fat in your tongue. That might be part of the mechanism of Zepbound's action for sleep apnea. Like we want you to lose fat and lose it in the right places that are affecting your health. And so the way they collect data and get FDA approval right now is based on that % of weight loss. And so there are going to be some other medications eventually that likely are designed to help increase lean mass while decreasing fat. And so their percentage of weight loss may be lower, but the body composition may be better. So that was like a hot topic at our conference this past week is how do we measure muscle more? How do we measure muscle function, right? Like it doesn't matter how much muscle you have if you can't stand up, right? Like, so these are like some of the emerging things that we're going to have more discussions on. And we just don't have like official answers yet.
Do you look at your patients like through DEXA scan, or do you analyze their muscle?
We do not use DEXA very often in our clinic. Some of the docs will occasionally refer for that, but we use bioelectric impedance. So we have in-body technology that we have always used in our clinic, and we're starting to try to incorporate grip strength in our testing, but we haven't quite got that worked in. But that's like a proxy for overall, muscle strength, and that can give us idea when people are starting.
Grip strength is a representation of my whole body muscle strength?
It's a proxy, right? Okay. So it's a proxy. It's safe. It's easy to do in clinic. I was talking to someone at the conference and they were like, well, we're thinking about having our standard metric be a deadlift. And I was like, all right, number one, people injure themselves as someone who herniated a disc doing a lift. Like, no. Like that is a highly dangerous movement. Some people can deadlift, patients that come into my clinic, I also CrossFit with them. They can deadlift 400 pounds. You know what I mean? Like, I'm like, this is not the standard tool you want to use.
Not a fair metric.
Grip strength is one of the more standard ones in the literature. That's kind of like a proxy for sort of like frailty and for strength. So, it's not going to tell you everything if all you do all day is practice grip strength and you've never done a squat, but it's sort of a good proxy of where someone's at.
So when you say bioimpedance, you're not using the $30 Renfo with the 2 points,
No,
right?
no. I mean, I bought one because I've heard good things, but it's sitting in the cabinet over here. I haven't tried it yet. And I think those are better than nothing for tracking at home, some of those home scales. But yeah, the one in our clinic, I think was like $13,000 or $14,000. So it's
Yeah, there you go.
supposed to be a little more highly accurate, but yeah.
Well, you talked about muscle and how we want to keep muscle, lose fat. Do you have strategies that you help your patients with to direct them in that vein, and what are they?
Totally. So we always give nutrition strategies. We recommend our patients eat at least 3 times a day. They eat protein first, and we give our patients protein goals. There is starting to be more literature on this. The standard minimum that anyone should be having protein wise, especially on medications, is 60 grams a day. But my target for women is 100 and my target for men is 120. I like nice round numbers that people can remember. People can eat more than that. Like, certainly, and certainly there's people out there recommending more, but those are nice, like doable goals. So that's where we start for people. So protein and eating it throughout the day is helpful. And then resistance training, really any exercise is going to help with that lean mass preservation. So that could be walking, yoga. It doesn't have to be anything intense, but I like people to also develop a little function there. So, again, my program, GLP Strong, like we have people do squats or squats with modifications, push-ups against the wall, because these are functional movements too, that as we age, we want to be able to have. So, but the importance of exercise, and we meet people where they're at, right? If someone, I have people who sometimes can't walk to their mailbox. Like we start with just getting people to be able to walk 1 or 2 minutes, but it's amazing. We have people who start there. And then, I have patients who've run half marathons. I have one patient actually who ran some 100-mile race last year. I mean, so, you never know what people are capable of. And so, I think it's, unfortunate that sometimes patients with obesity are thought of as like not athletes, because they absolutely are athletes.
Well, yeah, as someone who ran 2 half marathons, about 40 pounds overweight, I can attest to that. I had a really good question in my mind, and it just slipped out.
Powers are not working.
Okay, I'll think of it in a minute. No, go ahead. I'll think of it in a minute.
Well, so I know you like to draw the difference between a nutrition plan and a diet. Talk to me about that.
Yeah. So, I think a diet comes from a mindset of being restrictive. That's what we culturally in the US, I think, mean when we say a diet, right? A diet's really just your pattern of eating, in the more loose sense. But when we think of diet culture, we think of like restriction, lots of rules, black and white eating. And, there's patients for whom those are appropriate strategies. I'm not against meal replacement programs. I'm not against keto. But the really wonderful thing about using these injectable medications is that patients don't have to be so restrictive. And so I find for myself, as well as for my patients, that coming from a place of, well, what do we need to get in a day is more powerful, right? So how much protein do we need to build muscle and reach our goals, whether that's an athletic goal or whether that's a body composition goal, whether that's a frailty goal? How much protein do we need to get in? How much fiber do we need to get in? And let's be mindful of the quality of our food. We probably shouldn't eat fast food every single day, but if you were eating it 3 times a day and now you're eating it 1 time a day, we're going to, meet you where you're at. So, those are the approaches I like to take. And I never, ever have offered nutrition advice to someone without getting a diet history. If I don't know what you're eating right now, then I'm not going to tell you what you should eat, because I'm in Denver. People are healthy eaters here. Like if I just be like, well, you should eat more fiber and you should eat more protein. And they're like, I'm doing all that stuff. You know what I mean? People here don't eat fried foods. My patients almost never drink soda. They're not doing these obvious things that doctors tell them not to. Well, maybe you should drink another something. I haven't drank soda in 20 years. What are you talking about? So compared
to North Carolina, where everybody eats fast food and drink soda, right? I mean, seriously.
I realize that I'm in a different place, but I also, I think that has made this such a more fascinating profession to me, because I'm like, this is a healthy place. A lot of my patients come in and they do exercise, and they haven't had a soda since they were a kid, And so
they're doing all the right things, and yet they're still overweight. And why is that? Yeah. Interesting.
Yeah. So I think it's important. No, if someone is drinking a lot of soda or sweet tea, well, okay, we'll hit that low hanging fruit, because that is the stuff that's hardest on your body. But I think ultimately one of the harms that I think my profession has often done is we just give people nutrition advice without asking what they're eating. And we don't do that for other things. When I lecture, I talk about, ankle pain. If someone comes into my clinic with ankle pain, I don't just say like, oh, we'll take some Advil. Like, I'm going to get the history. Did you injure it? Have you had this before? Where does it hurt? I'm going to do an exam. And then I'm going to figure out if they have gout, if they have tendonitis, if they have a fracture, and I'm going to treat the right thing. And so when we just look at someone's BMI and we tell them to do a certain thing, that is not comprehensive care. And our patients deserve to be looked at holistically and have a whole treatment plan, not just be given a medicine, not just be told to drink less soda. They deserve this comprehensive approach.
I mean, that sounds wonderful. And can I move to Colorado and be your patient? I mean, that's just not really something that we see a lot of. And it's so needed, right? I wish more doctors had that point of view.
Yeah. Well, I've taught a couple hundred of them, so I'll keep trying.
Keep going. Yeah. I remember my question of what I wanted to say before about muscle. So talk to me about gaining muscle. Is it possible to gain muscle on this GLP-1 journey?
I did not set her up with this question, but absolutely. Now that doesn't have to be a goal. And, one of the lectures I saw this past week was like, that shouldn't be the goal, but it can be. And I absolutely see it happen. I have a partnership with the CrossFit gym in my area. And so sometimes it's people who are going to the CrossFit gym and they're not getting results they want from just diet and exercise alone. And sometimes I send my patients to the CrossFit gym. But when we see people consistently moving and consistently doing resistance training, they absolutely can lose fat and gain muscle. And that's the dream, right? So if you do resistance training and you eat protein, you can put on muscle while losing significant body fat.
In a calorie deficit. Yeah.
Well, so talk to me though about because we have lots of viewers. I mean, I've lost 100 pounds, but we have viewers who have lost 200 pounds who have been at the very high end of morbidly obese. So when you look at muscle loss, inevitably, if you lose 200 pounds, you're losing muscle. There's no way around that.
I would say on average, yes. And that would totally be my standard answer, but you don't have to. I mean, not everyone does. We have people who have all of it or put on muscle.
But the question becomes not how to optimize for a 500-pound person. It's how do I optimize for where my goal weight is, right? For if I want to be 200 pounds, whatever it is. So what's the right percentage? Does that make sense?
Totally.
Inevitably, I don't need as much muscle to carry around 200 pounds.
And so there's number one, there's this sarcopenic obesity. So these are people who have low muscle mass and frailty. It's not just about the amount of muscle, because those people may still have the same amount of muscle as I do, but they're frail, right? It's not strong muscle. But then there's also people who come in and they have like 3 times as much muscle as I do, right? And so those people can lose muscle while they're losing fat as long as they're preserving their function. Like they have plenty of muscle to spare in their weight loss journey. And so we also need to identify those people who are coming in with obesity, but with low muscle mass. And those are the people we need to be more aggressive with, because they don't have the muscle to lose, right?
Yeah.
Which is where you see all those flags for, basically 70 and 80-year-olds on these medications, and they're already down in their muscle mass.
Right.
Yeah. Well, and it's interesting because we have the Renfo scale, right? That's our only, and I can get like a quick directional reading on muscle mass and body fat percent and water percent, all kinds of different metrics, not just the weight number. And I lost about 50 pounds, and not quite half of that was muscle, but about 40% of that was muscle. But looking at my muscle on the chart, I had a lot of muscle to start with. So I don't know, maybe that makes me feel a little bit better what you're saying.
Absolutely, right? Absolutely. And then the function is the thing that's also important, right? So can you do a squat? Can you bend over and pick things up? Can you push yourself off the floor and get off the floor? Can you reach up and, get your suitcase off an airplane? These are sort of functional movements. Those are kind of basic things that I think most of us do, can you do those movements, and can you do them consistently? Well, then maybe there's not an issue. If you're struggling to get out of your chair, then that that would be like a sign of frailty too. So this is the conversation that's going to evolve, over the next few years. And hopefully we'll start more standard measurements on these things and more standard guidance on these things, because that's been one of the biggest things in the media, right? Is the lean mass loss. Well, you are going to lose most people are going to lose some lean mass. Some of that lean mass is water that's in your adipose tissue. Like it's not all like muscle that you're losing when you lose lean mass.
Oh, but that's where I think people get lost on DEXA scan, because DEXA scan doesn't actually measure muscle, right? So
right. And all of these are like a little bit of proxies to measure, muscle as well. So that's where the functional component, which again, like the two tests that are sort of emerging as the most popular is there's one where you can see how many times people can like stand up out of their chair like this without, having to support. So that's one test. And then another is like grip strength. And so some of these standard tests to be like, is this person okay? Right? Like what can they do? And for the most part, any amount of exercise is going to protect you from that. And so, on the label for, Wegovy and Zepbound is like, this medicine is with a low calorie diet and increased physical activity. So, we can't make people exercise. Lots of thin people don't exercise, but we should be encouraging that. And when we follow up with our patients, we should be like, gradually, where are you at now? Oh, great. Like now you're walking 5 minutes a day over your lunch break. Fabulous. Like let's keep pushing that, because a lot of the data shows it doesn't have to be that much. You do not have to go to CrossFit 5 days a week to get these results. We're talking like 20 minutes twice a week. And that's what our program is. It's twice a week, twice a week of strength training. It's not designed to be, you got to weight lift every day. It's just a little bit of strength training, but even walking or yoga is going to help. So, it's pretty mitigatable.
Yeah. All the movement matters. It all adds up. And 20 minutes twice a week is very approachable. You know what I mean?
I hope so. I felt like it was.
Yeah. Well, I'm a big exerciser. And my husband is not. So we have this debate in our house as
there's no debate. I agree with her. I'm just not going to do it.
And I mean, I don't want to, put you in the spotlight or anything,
but you will nevertheless.
Put you on the spot. But, how do I encourage a loved one to get more exercise?
I haven't figured it out. So, I joke that I will win the Nobel Prize if I figure that out. I mean, I just don't know. Some people like it, some people don't. And so for my patients who are just like really hate it, I'm like, look, you have two options. You can treat it as a medicine that you have to take every day and you just do it. And it's just a check on the list. And we all do things we don't want to do, whether it's get our kids out of bed and make them go to school in the morning, which is like my least favorite task, but I do it. It doesn't matter if I like it or not, right? I have to do it. Or you really figure out ways to incorporate that movement in your life, whether that's gardening, walking to work, what are ways that you can move, but it doesn't feel like that forced exercise, which some people don't like. And so, but those are sort of the two main strategies is and then having someone else make you do it. So if you have the budget for a personal trainer, if signing up for something like Peloton or something that gives you that accountability helps. So, but at the end of the day, I think part of it is it's felt like a punishment to some people with overweight and obesity. Sure. And, I like to normalize it. Like we all should move more. We all live longer and better when we move more. And so it's not like a punishment or something that only people who are working with their weight need to do. It's something we all should be doing. Like it's like brushing our teeth. We all have to do it.
I mean, the punishment part, for years I punished myself. Like I would push myself to extremes with running, with aerobics, with, whatever I was into at the time. And now I look at it differently now. I look at it as something that I get to do or I want to do that I enjoyed. I don't run anymore because I always hated running. I hated it. I hated it so much.
People do hate running. Yeah. And it's fine. If you hate it, don't do it. Walking is fabulous.
Yeah. Why was I doing it? I was doing it to lose weight and it never worked. So now I look at exercise not as something I need to do to lose weight, but more something to be strong. And as I get older, to be able to get up out of my chair and balance and all, not fall down and break a hip and all that stuff. So I can very much relate to that.
Fortunately, my scale says I only lost 9 pounds of muscle. So
Right,
Right?
that's amazing. Because you said you
I
lost
lost more muscle than
100
he
pounds.
did. Yeah, no, and that's what's maddening to me is because here's me eating the 100 grams of protein, working out with weights 3 to 5 times a week, doing all the things. And of my 50 pounds, I lost about 20 pounds of it was muscle. And here's Mr. I lost 100 pounds and lost 9 pounds of muscle. Like,
Yeah.
I needed nothing.
None of those machines are perfect. A lot of them will make some calculated judgments based on gender in the inputs you put
Yeah.
in. Try it.
Yeah.
Does the Renfo
Okay,
ask if you're
so
male or
it's twice that. I lost 18.
What'd you say?
Still significantly less than the research says.
This is just a point of contention between us.
It's not.
I'll get yelled at in the comments
like,
too.
really
All
part of
the
my interest in
ladies
this
will
field
yell at me.
is like the advocacy side. A lot of this stuff isn't fair. You know, it isn't
Right.
fair. People with type 2 diabetes have different body composition changes. Menopause affects body composition. Like it's just like, and some of it's just not fair. And like, you know, all sorts of terrible things happen in medicine to my patients that like, I'm like, I can't explain why you got cancer, you know, like sometimes we just have to like accept our bodies a little bit and be like, this is what my body does. And you can't compare it to other people.
Right. It is a personalized, even with, weight loss, it's no one loses weight the same. Doses are different. People eat differently. It's very personalized. And I think we just need to try to remember that.
So let's talk about eating a little bit more. So you obviously don't recommend one specific diet for every one of your patients, which I think is refreshing.
Yeah. Yeah. I mean, you know, over time, I have gravitated more to what I call the healthy eating plan, which is like pretty standard, like, you know, eat more vegetables, like it's a pretty standard, but it's designed to be flexible. So if someone really is passionate for whatever their reason is about being plant-based, we work within plant-based. If someone, is really passionate about, being paleo style or has dietary restrictions, like there's no food I tell people they need to eat. It's sort of like, you need to get protein in, you need to get fiber in. What's the best path there? I have one patient right now who just like can't eat vegetables. She probably has a bit of like an avoidant restrictive eating disorder that wasn't addressed when she was a child, but she's like 50 years old. And I'm like, I don't think that is what we're going to work on here. And so I'm like, just, you don't have to eat vegetables, right? But you need fiber. So we're going to focus more on whole grains for you. Right. And so, meeting people where they're at. But I also, if something makes sense, like when people come in and they still like the keto diet and it's still working for them and they don't need a medicine because they've done keto for 10 years, like, great. That's a strategy that may be appropriate for them. So I hate the diet zealots, right? Like, you can't get a room of 10 doctors in the room to agree on what's the best diet. So if anyone's telling you there's a best diet, they're wrong.
I just know we get the most common request for video we get is what I eat in a day.
What I eat in a day.
And I am never doing a what I eat in a day video. And honestly, it would just be boring. And I tell people that because I have done the simplest version of this possible. We eat fresh food, meats, fishes, we eat vegetables, and we have minimized carbs and processed foods.
Yeah.
That's it. We haven't stopped anything. We've just minimized them. And I don't use recipes because I've cooked for 30 years and I grill, roast, whatever. So I'm like, you guys would be bored. It's just not that interesting.
But we haven't eliminated foods either. So, this past weekend we had ice cream. You know what I mean? Like I don't want to, people want an example to follow. And I'm like, don't be following me.
And that's a struggle I've had with my patients too for the years. It is like, they want, a specific plan. And I'm like, well, what do you like for breakfast? And they'll tell me a few things. I'm like, cool. Like, I think that your best choice of those is the Greek yogurt. Like, let's stick with that. Or, like, how can we get protein in if you're having some oatmeal for breakfast? Like, how do we, work with what you like? And I agree. Like, and the data says that the boring diets are, what's going to help with maintenance, right? If you're just eating foods that you enjoy, grilled meats and vegetables and eggs or whatever, like stuff that's like, it's good, it's nourishing, you enjoy it, but it's not hyper palatable. And it's kind of the same thing over and over. You're not going to overeat it because it's not that exciting.
No.
Oh, no, it's exciting.
Okay. Well, maybe it is exciting.
Well, because I've gone to this place where we spend so much less and buy less volume of food that the quality of food we buy has gone up. So if I'm going to buy a steak, I'm going to buy the best steak I can find. If I'm going to buy a piece of fish, it's going to be a whole fish and I'm going to grill it and it's going to have herbs and it's going to, all those things that add flavor that don't have calories, herbs and all those things.
Maybe we do need a cookbook from you.
Yeah. Well, and also like I eat so much less food now that I don't want to eat something just to eat something. You know what I mean? Like, I'd rather not eat.
Yeah.
So if it's the same old boring food, I'm going to be like, eh.
Oh, interesting.
You know what I mean? So I want to make the things that I do eat interesting and things that I like that taste good. Otherwise, I'd rather not bother. But I still
And
try
that
to.
is the beauty of being on a medication is
Yeah.
the
Yeah. And I couldn't do
enjoyable
that before.
foods.
Yeah.
It's easier to eat them in moderation, right?
Right.
Without the medication, those more enjoyable foods can be harder to eat in moderation.
Yes, for sure. Instead of eating the whole gallon of ice cream, I have a cup and then I'm great till, the next month when I maybe think about ice cream again. Where before I was thinking about eating it like every time all day.
So what are some of the biggest mistakes you see people making when they start these GLP-1s?
Like patience.
Yeah.
I think
Or
just
doctors. That's a fun
yeah,
one
I
too.
think just like trying to be too aggressive with it. This is a slow process. Like some of the results are amazing quickly with both Wegovy and Zepbound, right? Like people lose 10, 20 pounds like their first month. But the weight loss continues for like, at least with Zepbound, more than a year, right?
Yeah.
So there's no rush. And so, if you are having side effects, like it's okay to just stay at a low dose until those side effects feel comfortable to you, or go away. So I think like people rush to get to the highest dose of medication, and put up with too many side effects, and then it's not as good of a process, or they're not able to eat as healthy foods. Because if you're sick, like you're not going to eat like fish. I would never eat fish if I wasn't feeling good, right? If I was nauseous, like that wouldn't appeal to me. So we don't want to be so like aggressive that like people are eating nothing but like bread and rice and bananas, because that's not going to be a balanced diet, and it's not going to be ultimately conducive to metabolic health. So I think just being too aggressive and like just, being patient. These meds, they work like 90% of the time for people. So like be patient, follow the dose escalation. It's okay to go slower than that, and let your body sort of adjust, let your side effects adjust so that you can have the best results.
The occasional person, 90%, these medicines work for 90%. Have you seen anyone that truly it does not work for? It was nothing they were doing. It was just they were doing all the things and it still didn't work?
I never know if someone's doing all the things. So I have, I guess the one patient I think of, I don't think is able to do all the things. She's had a lot of health challenges physically and mentally, and thus far has not had very good results. And this is a good point that the medications, like they can't overcome poverty, they can't overcome illness. Like they can only do so much sometimes. If there's food insecurity and you can't get consistently healthy food, the meds may not be as powerful. And then I have one patient who really has had a very mild response to the medications. She's just very weight resistant, like weight loss resistant. I've worked with her for like 8 or 9 years, I think. And like nothing has ever been like really dramatic. And, her body has just adapted really well to conserving energy and maintaining weight. It's really good at that. She would survive us all if we were voyaging across the world. So, she's one where I'm like, I don't know, like nothing seems to work well for this person.
Yeah.
And then occasionally the people who things have not worked well for, I find out that there really is something going on. Historically, binge eating is something I would see, though these medications seem to work very well for my patients with binge eating disorder. But alcohol abuse is another thing that can really keep people from losing weight. So if you eat really healthy, but you have, 5 to 6 drinks a night, you're not going to lose weight. And so that's another one where it's like that sometimes doesn't come out in the story.
Yeah. Interesting. Because I mean, occasionally we do hear people that are like, this just doesn't work. And I'm like, really?
Yeah.
I mean, I'm sure there are, like you mentioned, a few, but I always wonder.
And then
if that's
keep in
really
mind
the case.
too, patients with type 2 diabetes, it is much harder for them to lose weight. So
Yeah.
they are actually only like 80% likely to lose weight on these meds. And no
Oh.
one has a great explanation. I did a podcast with Harold Bays, who's like, the expert on diabetes and endocrinology and weight loss. And he's the journal for our editor for our journal. Like he is like, and all of his explanations, I was like, I don't know if those fully explain why it's harder for people with type 2 diabetes to lose weight. But so that's another group that it's just a lot harder with type 2 diabetes. So patients with type 2 diabetes shouldn't expect to have the same weight loss results as people who don't have type 2 diabetes.
Well, and it's where it becomes exciting in the new things in development, because when you get those extra methods of action there, the glucagons and the amylins, and there's a lot of stuff going on out there. Maybe when you have more tools, you'll find the tool for that person.
Absolutely. Yeah, I think absolutely. And then we can't forget that surgery is still out there. So if people really would benefit from a significant weight loss, surgery may be the more durable, more effective option for them.
I was really surprised. We talked to a lady the other day that had bariatric surgery in 2015. Are people still having bariatric surgery? Is it still a recommended course of action?
Absolutely still recommended. And the rates are going down largely because of the medications. However, it is more affordable because it's, you invest, whether it's you're investing your own money or often it is covered by insurance.
Our insurance I could have had it if I'd wanted.
Yeah. And so right now it is still the highest amount of weight loss and the most cost effective for those large weight losses. So, it's still happening for sure. And so again, people who the medication, they can't take it for some reason, it doesn't work out, but they would benefit from, a 20% weight loss. It's worth meeting with a surgeon to see if that's a fit.
Interesting. Yeah.
So for people who have been watching now for almost an hour and they see Dr. Francavilla and they're like, how can I find a doctor like that? Do you have any suggestions for patients? Obviously not in Colorado because they come to your practice.
Yeah, if you're in Colorado, check us out at Green Mountain Partners for Health. If you can spell my name, you can find me. The Obesity Medicine Association.
We lost your camera.
We lost your camera.
Oh no. Well, you'll just have to listen to me. I'm sorry.
That's okay. That's okay.
I don't know what happened to it. Nothing changed. I still look the same. I'm still in the pink sweatshirt. The Obesity Medicine Association has a list of members, as does the American Board of Obesity Medicine. That's going to be doctors who've taken an exam to become a specialist. And then I think nationwide, there are some companies that provide more comprehensive care. A colleague of mine, Angela Fitch, just went nationwide with a company called Known Well. And she's, an expert in the field and offers comprehensive care, and they're doing virtual visits nationwide now. So, there are these people, they're just, sometimes harder to find.
And so telehealth isn't the bad guy. There are actually good telehealth options.
I think there are a few good telehealth players, but if they're selling compounds, to me, that's a red flag. And if they are never having a discussion with you, if you're only filling out a form to get your medication, you might message them later on to get care, but you should have a discussion with someone in the beginning because there's a lot. My intake is 60 minutes and I need 90, so there's a lot to find out about people before you start them on a medicine.
Yeah.
Well, so tell us more about your podcast and your YouTube channel.
Yeah, so the YouTube channel is just me, on the podcast, but it's the Dr. Francavilla Show, and the podcast is on weight and health. Really, we talk about all of these topics. I always recommend starting in the beginning. The first 10 episodes are a lot of my core topics, but we explore the medications. We explore different dietary strategies. We explore a lot of mindset things. I have wonderful colleagues that come on and explain their area of expertise, and it comes out every Monday. And it's short. It's usually about 30 minutes. So you can, catch it on a commute on Monday morning and hear the latest and greatest.
That's exciting. So I'll put a link in the description. Make sure you guys go subscribe to her channel because I watch it every week.
Oh, thank you so much.
Lots of good information. So that's it for us today, though. Unless there's anything else you'd like to add, Dr. Francavilla?
Nope, I think the camera told us that we're done anyway.
It's all
So
good. It's all good. All right. So this has been the Downsized. If you haven't already, please like and subscribe. Make sure you go to Dr. Francavilla's channel and like and subscribe as well. My name is Christopher Durham.
I'm Laraine Durham.
We are the Downsized. We'll see you next time.
Bye. Thanks, Dr. Francavilla.
bye. Thank you.
Thank you.